Thank you, Billy, and thank you, Lesero, for this opportunity to present, share the topic today with you on your platform. My name is Depo Rabutata, as Billy has already mentioned. I just want to share with you what our mornings look like in the VAL. So I'm not sure if my screen is projecting on the other side. Thank you. So this is how we wake up every morning in the VAL, regardless of whether it's summer or winter, quite a cold place. But nonetheless, we always look forward to our magical sunset. So it's quite a lovely place to work in, a nice small town with a small community. So today I'm going to share a presentation with you about an overview to contraception. So I'll just get to it because there's quite a lot to cover. It is quite a broad topic. So by definition, contraception is deliberate use of methods or techniques to prevent unplanned and unwanted pregnancies. This actually is not a new thing, not even in the 20th century or even earlier. This started in about 1850 before Christ, where there was a practice of use of honey as a spermicide to prevent unwanted and unplanned pregnancies. The use of crocodile dung, as well as acacia leaves and lint to form cervical caps to prevent sperm from entering the womb. And lactating women would actually lactate post-delivery for about 3 years to induce lactational amenorrhea, which we'll speak about shortly, and that was also a contraceptive method. And for those of us who visit the Bible every now and then, you would remember from the book of Genesis that there's a verse that says, Onan spills his seed on the ground so as not to father a child with his deceased brother's wife, Tamar. And that was actually depicting coitus interruptus. So it is actually shocking. In 2016, Statistics SA showed that there was about 20% of unwanted pregnancies in South Africa. And this is quite sad because contraception is quite available. And maybe we are not doing enough to give it on to our patients. So the scope of discussion, like I said, it will be quite broad, but I've tried to give an overview and summarize. We're going to look at natural contraception, barrier methods, hormonal contraception, as well as non-hormonal contraception. So we'll start off with the natural methods. So these are the least reliable methods. The first one that we'll talk about is lactational amenorrhea. So from physiology, you'd remember that suckling stimulates production of prolactin, and prolactin via negative feedback will inhibit the release of gonadotropin-releasing hormone, which then suppresses the release of luteinizing hormone and follicle-stimulating hormone, which will then suppress ovulation. So this is one method that we should also be discussing to our patients. There are patients that are actually reliable on lactational amenorrhea on its own. It is not a reliable form of contraception. The next one is the one that I mentioned a few seconds ago about coitus interruptus. And this is where spermatozoa are not deposited into the vagina, and thus trying to reduce unwanted and unplanned pregnancies. The calendar rhythm method, this method, basically you need to identify your cycle length and make sure that you avoid having contraception, you avoid having a coitus in your fertile days. So if you look at this, I'm not sure if this pointer is showing, but you'll see that your safe periods will be the first 7 days of your cycle, as well as the last 7 days of the cycle. And the broader 14 days, that's where you would be fertile. So those are the days from day 8 to roughly about day 19, where you should avoid having intercourse. Temperature method, also not so reliable, something that was used in the past. So basically this entails taking your basal body temperature every day around the same time. This should be done in the mornings. And you just want to identify the rise in your basal body temperature by about 0.5 to 1 degree Celsius. And when that happens, that would be indicating that the patient is now ovulated and should avoid having coitus. The problem with this is that you can imagine if the patient identifies that she's ovulating at that point, and she had intercourse a day or two, or within 5 days, she would be in trouble and will most likely fall pregnant, because spermatozoa can last up to 5 days after intercourse. So also not a reliable method. So we'll talk a bit about the barrier methods. So the condom, diaphragm, cervical cap, as well as the sponge. These methods can be used with or without a spermicide. We'll talk a bit more about spermicides as well. So condoms, male condoms, we all know. Female condoms, I think we're not doing justice to this, because we almost always focus on the males and the male condom, and we don't really promote female condom usage. And this is something that can be done and can be used to empower women as well, where women goes around carrying either male condoms or female condoms. But we just need to spend a bit more emphasis on female condoms as well. The diaphragm is made of latex or silicone. It should always be used with spermicides. It should not be used for more than 24 hours. It should be left in place for up to 6 hours after intercourse, because if it's removed earlier, then pregnancy risk increases. However, it's important to know that there's increased risk of urinary tract infections, as well as the toxic shock syndrome, especially if left or forgotten inside for a long time. Cervical cap is quite similar to the diaphragm, but you can see it's different. So this is more plastic dome shaped with a suction. These the diaphragm and the cervical cap, these are actually administered by or inserted by the woman herself. This should also be used with spermicides. Should not be used for more than 24 hours, and just like the diaphragm, not to be removed within 6 hours after intercourse, with similar side effects or adverse effects with the diaphragm. The sponge, it's made from foam-like material. It's placed 24 hours before intercourse. So you need to know, I guess, the woman needs to know when she's going to have intercourse. So that's how impractical it then becomes. Should be left in place also for 6 hours after intercourse, and it should not be used for more than 30 hours after. Should not be used for more than 30 hours, because that's when the risk of toxic shock syndrome increases. It can also cause irritation, and these it doesn't provide any protection from sexually transmitted infections. Spermicides, these should actually be used with barrier methods. Typically, they are applied about 10 to 15 minutes before intercourse, and they're effective for about an hour. So the most important ones now, well, not really most important, but the core of the presentation, hormonal contraceptives. So these are divided into short-acting as well as long-acting reversible contraceptives. The short-term hormonal contraceptives, we'll start off with the pills, injectables, and patches, as well as vaginal rings. Injectables, most of us will be familiar with the Depo Provera, medroxyprogesterone acetate, which is injected intramuscularly. It's 150 milligrams every 12 weeks. What's important to note here is that this is associated with amenorrhea in about 46% of patients. So thorough counseling needs to be done. We've had a lot of patients that come in complaining that they're not seeing their periods because they are on contraception, they're on the Depo, and they are just not happy. They think that it's harming them and they want to stop using it. And in fact, if they get amenorrhea, that means the contraception is effective and they should be continuing on it. Added benefit, reduction in the risk of endometrial cancer, and also the amenorrhea itself can be used in most medical conditions, which we'll talk about in a few minutes. Nitrate is administered also intramuscularly. It's about 200 milligrams, and it induces amenorrhea in about 8 to 25% of cases. So also thorough counseling to inform patients that they might experience amenorrhea. I think it's important to mention the ECHO trial while we are here. How do I go back?
Can you use the arrows on your computer?
Thank you, thank you. So the ECHO trial, while talking about medroxyprogesterone acetate or the Depo Provera, there was a bit of concern a few years ago where the use of Depo Provera was associated with increased risk of acquiring HIV. And because this was quite a concern, there was a large trial done, which was called the ECHO trial, where they looked at the use of Depo Provera as well as copper IUCD and the subdermal implant, progesterone releasing implant. And these three were compared. And it was quite a large trial composing of 12,750 women, and all of them evenly spread out in the three groups. The conclusion from this trial actually showed that there was no substantial difference in the risk of HIV infection among women using any of the methods. So the women that acquired HIV were comparable in all groups. So this should actually put us at ease when we prescribing medroxyprogesterone acetate or Depo-Provera or Petogen. We're just going to have a few words on the transdermal patches. These contain both estrogen and progesterone. There's about 9% failure rate when they are used. New patches, so the way it's used is that you would apply a new patch every week for 3 weeks with 1 patch-free week. So that means in a month, the first 3 weeks, the patch will be applied, and on the last week, there will be no patch. And this is to induce withdrawal bleeding so that the patient can see her periods. The perfect example will be the Evra patch. It's important to know that side effects that should be expected is things like skin irritation, as well as other side effects and contraindications that are similar in combined oral contraceptives, which we'll talk about in a few seconds. Other option is a vaginal ring. The vaginal ring also contains both estrogen and progesterone. There's about 9% failure rate when using the ring. The ring is inserted into the vagina. It's quite flexible. It's left inside for about 21 days. So 21 days, the ring is inside, and then it's removed for the last 7 days of a typical 28-day cycle. And also, just like with the Evra patch, the removal is to induce withdrawal bleeding, which will be perceived as menstruation by the patient. Side effects include vaginal irritation as well as a discharge. It's important to note that the risk of pregnancy increases if the ring falls out. So the patient needs to regularly check on the ring to ensure that it's still in place. So this becomes a bit of a problem for some patients who are then uncomfortable and always have to check and see that the ring is there before having intercourse. So it might also not be quite practical in some patients. It can be removed for up to 3 hours without losing the efficacy of the contraception. And also it can be removed during intercourse if preferred, but intercourse can actually continue in the presence of the ring. Contraceptive pills. These are mainly divided into combined oral contraceptives and progesterone-only contraceptives. So combined oral contraceptives have about 9% failure rate, and in about 14% of cases, they can be used for other gynae benefits or other medical benefits, such as in patients with abnormal uterine bleeding, acne, and hirsutism, among others. There is actually a quite long list that we'll discuss in the next few slides. Also important to note that combined oral contraceptives have about a 50% risk reduction for endometrial cancer, 27% risk reduction for ovarian cancer, and 18% risk reduction for colon cancer. So it is that means it is protective against endometrial cancer, colon cancer, as well as ovarian cancer. So the mechanism of action of the combined oral contraceptives. So the main contraception in combined oral contraceptives although it contains estrogen and progesterone, the main one that provides contraception is actually the progesterone. Estrogen also has a part to play, but the main one is progesterone. So by giving the patient the end hormone, which is progesterone and estrogen, the high levels of the drug that are now circulating in the blood system will now give a negative feedback to the hypothalamus, therefore suppressing the release of gonadotrophin releasing hormone, which will end up preventing the release of luteinizing hormone and follicle stimulating hormone. And we know that when luteinizing hormone is suppressed, you will be suppressing ovulation. And by suppressing follicle stimulating hormone, you suppress stimulation of the Graafian follicle, which will then result in reduction in production of estrogen. So basically, this is just to sum up what I said, but the progesterone effect, other than the negative feedback mechanism, which is number one, it also has other contraceptive benefits, such as thickening the cervical mucosa. So in the cervix, the mucus, there'll be cervical mucus plug in the cervix, which will be very thick, and its main function is to prevent penetration of spermatozoa during intercourse. It also causes endometrial atrophy. So the endometrium is the inner layer of the uterus. And if the inner layer of the uterus is thinned and made unfavorable for implantation to occur, this then gives the contraceptive benefit. Additionally, it also causes suppressed peristalsis in the tube, inducing slower motion of the tube, and this prevents the egg from entering the tube or moving within the tube. The end goal is that the egg and the spermatozoa should not meet, so that there is no fertilization. So this is similar to what I explained. Non-contraceptive benefits of combined oral contraceptives, quite a long list. As I mentioned, reduced risk reduction in endometrial, ovarian, and colorectal cancer. It also improves bone mineral density. The COCs can be used also for management of irregular menstrual cycle, treatment of amenorrhea, induction of amenorrhea. There might be patients who desire not to see their periods because they have heavy menstrual bleeding, dysmenorrhea, pain during their periods, or maybe they are going on a honeymoon and they don't want to spoil things for the newlyweds. So therefore, a patient might desire amenorrhea to ensure that the honeymoon remains a honeymoon. They can also be used to prevent menstrual migraines. They can be used for the treatment of acne, symptom relief in some patients with multifibroid uterus. They can be used in the treatment of dysmenorrhea, hirsutism, heavy menstrual bleeding, pelvic pain, premenstrual syndrome. It's quite a long list, but these are among the common ones. Very important, dosing. So the typical combined oral contraceptive pill will contain about 21 active pills with 7 placebos. So the real active pills are the first 21 pills for the first 3 weeks, and the last week is just placebo. And when the patient starts taking the placebo, there will be withdrawal bleeding, which will be perceived as menstruation. The use of placebo is used to encourage compliance, so that the patient doesn't have a period where she stops taking the pill. So the pill is taken every day. So dosing depends on whether the patient desires, or medically, whether the patient desires withdrawal bleeding. So in some patients, we might not want them to bleed because we're using it medically. Some patients might not want to see their periods. So there's 3 main dosing modalities. There's a cyclic modality, which is typically like this pill where the patient will take 21 active pills, followed by the 7 placebos, and menstruation will follow. There's also the extended cyclic. With the extended cyclic, the patient will only see their periods after 3 months. So if the patient is using the usual pills, she will then skip the placebos. So she'll take the 21 active pills skip the 7 placebos and move on to the next pill, skipping the next placebo as well. And only on the 3rd pack, she'll take the full pack where she takes the 21 active pills followed by the placebo so that she can see her periods after 3 months. There are also actually some extended cyclic pills that are prepackaged as such, and the pack will contain 84 active pills with 7 placebos, which will be taken at the end. Another dosing option, is the continuous dosing, where the patient will have no bleeding at all. So this is in patients where amenorrhea is desired, and they will be having no menses throughout. So that means not taking any placebo pills. Initiation, there's 3 methods to do it. The first day start, this is when you start the combined oral contraceptives on the first day of the menses. So if you remember from the calendar method, so the first 7 days are usually safe. So when a patient starts on the first day of the menstrual cycle, she starts in a time where it is actually safe to have intercourse. It takes about 7 days for the pills to kickstart and be active. So that will give the patient extra protection. There's also the quick start method, where the pills can be started on any day. So a patient comes today, consults, and then you prescribe the pills for her to start on that particular day. It's important to note that when the patient starts the pills, there will be no coverage or no protection for the first 7 days. So additional methods should be used. There's also another method called a Sunday start, where the pills are started on the first Sunday after the periods begin. Just like the quick start, there is no coverage over the first 7 days, so additional methods should be used by the patient. So what happens if a patient misses the pill? Also quite a common problem. Patients will call in and say, "Doc, I've missed the pill, what should I do?" Well, immediately when the patient realizes that she has missed a pill, if she misses the placebo pills, then obviously that's not an issue, because those are inactive pills. So there's no action required. So you just need to reassure the patient that there will be no issue. She should be seeing her periods anytime soon. If the patient misses the active pills, then the patient should take a pill immediately when she remembers. She takes 1 pill, and then she's going to take the next pill at the usual time that she was taking, even if it means taking 2 pills on the same day. But it's important to note and to counsel the patient that she should use additional forms of contraception for about 7 days, because that's how long it will take before she gets her cover. If there was sexual intercourse or sexual contact during the period when the pills were missed, or the pill was missed, then the patient should be given emergency contraception. Side effects of combined oral contraceptives, also quite a long list. Nausea, breakthrough bleeding is not quite common with COCs actually. Headaches, abdominal cramps, breast tenderness, increased vaginal discharge, decreased libido, impaired glucose metabolism, hypertension in about 4 to 5% of cases, impaired bone mineralization, increased risk of venous thromboembolism. This is an important one. Increased risk of stroke and myocardial infarction, cloasma, angioedema, increased appetite and weight gain, also an important one. Contraindications, uncontrolled hypertension, smokers, patients with breast cancer, patients who are known with ischemic heart disease, migraines with ORAS, endometrial cancer, cirrhosis, if they are used within 21 days after delivery, if the patient is breastfeeding. So the reading here is quite long. Within 21 days postpartum, if the patient is breastfeeding. So if the patient is breastfeeding, she cannot use combined oral contraceptives within 21 days. I should correct that. They should also not be used within 6 weeks postpartum if the patient is not breastfeeding. So I think this is the other way around. So patients that are breastfeeding should not be using combined oral contraceptives within 21 days. If they are not breastfeeding, then they So if they are breastfeeding from 21 days onwards, they can use combined oral contraceptives. If they are not breastfeeding, I'm contradicting myself. So patients that are breastfeeding should not use combined oral contraceptives within 21 days, and it should end there. And the age risk is quite relative, because we do prescribe, and there might be indications to prescribe combined oral contraceptives in patients that are older than 35. And the other contraindications: hepatocellular carcinoma, malignant hepatoma, history of subacute bacterial endocarditis, the risk of atrial fibrillation, pulmonary hypertension, combined hypertension and diabetes in the same patient, thrombogenic mutations such as prothrombic mutations, factor V laden, protein C, protein S, and antithrombin deficiencies. These are deficiencies that increase the patient's likelihood of having venous thromboembolism. So they should be, combined oral contraceptives should be avoided in those patients. Patients with high BMI, as well as patients that are post-major surgery. The progesterone-only pills, these would be mainly for patients that prefer using pills but have contraindications for combined oral contraceptives. So there's about 28 active pills with no placebo, so it's continuous. They must be taken daily at the same time with no more than 3-hour variation, and that's also what makes it a bit of an issue. Most patients will forget, and then increasing the likelihood of falling pregnant. The mechanism of action is as we've discussed above. These are the examples. I think there are many others, so we can pass through the side effects of progesterone-only pills include irregular bleeding, bone demineralization, acne flare-ups, mood disorders, as well as low libido. What do you do if a patient misses a progesterone-only pill dose? So if the patient missed the dose or vomited within 3 hours of taking the pill or had severe diarrhea, she should immediately take one pill as soon as she remembers, and then take the next pill at the next scheduled time. The difference here is that for the next 2 days, she would not be covered, so she should use additional methods. If there was sexual contact, then emergency contraceptives should be added. Contraindications of progesterone-only pills: women with suspected or known to be pregnant, undiagnosed abnormal uterine bleeding, breast cancer, acute liver disease, benign or malignant liver tumor, severe cirrhosis, history of bariatric surgeries, as well as patients that are on anticonvulsants. Important to note that drug interaction may affect the pills, so you need to take a thorough and detailed drug history. And also important to note that the common ones are the anti-epileptic medications such as phenytoin, carbamazepine, lamotrigine, and others. So the efficacy of the drug will be lowered, and the risk of pregnancy will be increased. So when you see a patient who comes in and you prescribe combined oral contraceptives, it should not end with her walking away, going home, given a 6-month script, and just continuing unmonitored. So some patients would, even after 6 months, when the script expires, would call in and request an extension of another 6 months script without even seeing you. So that practice would be completely wrong. So healthy women on combined oral contraceptives should have annual visits for blood pressure check, as well as routine medical care. Obviously, patients that come in like that and you give them scripts and they go, if they are attending elsewhere, maybe the patient goes to the clinic for other matters and she gets monitored weight and a blood pressure and a glucose, then that would be fine. But the patient should not be left completely unmonitored with no follow-up. Women with well-controlled hypertension should be monitored monthly, so monitoring the blood pressure every month. And pre-diabetic as well as diabetic women also monthly. And you should also monitor weight gain twice a year. So when you want to change from combined oral contraceptive pill to progesterone-only contraceptive pill, the way you do it is that you stop the oral contraceptives for about 7 days. This will induce withdrawal bleeding. Then you can start with the progesterone-only contraceptive, but alternative methods should be used because it takes about 7 to 14 days for the steady state to be reached and the efficacy to be maximized. And a few words on emergency contraception. If the patient had intercourse within 72 hours, then there's a few options. You can use combined oral contraceptives or progesterone only, taken as soon as possible in 2 divided doses. I'll give examples just now. If a patient vomits, then especially within 30 minutes, a repeat dose would be required, and you might actually have to add an antiemetic to prevent second vomiting. If intercourse occurred more than 72 hours, but within 5 days, there's still an option to use an intrauterine contraceptive device. So the few options for the combined oral contraceptives, the common ones would be the Nodet, although the dose is a bit, it's a lot of pills to take. So 4 pills immediately, and after 12 hours, 4 pills. Another common one would be Overall, where you take 2 pills immediately and 2 pills after 12 hours. Trifacil also made it to the list, 4 yellow tablets immediately and repeated for 12 hours later, same dose of 4 pills. Progesterone only, the common one that we usually use and see is a Nolevo, where one is taken immediately and one tablet repeated after 12 hours. So it comes in a pack of 2. Just a few words on long-acting reversible contraceptives. So there's mainly 2 ones. The subdermal implant. Implant is the one that we commonly have in South Africa, which lasts for about 3 years. And the intrauterine contraceptive devices, where the copper type can even be used for up to 5 to 10 years. Subdermal implant it releases progesterone, so it's progesterone containing. So the side effects will be similar. Side effects that you see with patients on progesterone contraceptive, as well as the same contraindications. The next one is the intrauterine contraceptive devices. There's 2 main types. I mean, there's many types, but the 2 main components would be the copper containing ones, as well as the progesterone releasing. So the copper containing ones, the common one that you see is copper T. There's also Nova T. This is typically how it looks. So it releases copper while it's sitting in the endometrium, and this makes the endometrium unfavorable for implantation. These are among the most reliable forms of contraception. It makes up there's a slight risk of ectopic pregnancy when a patient is using the copper IUCD as opposed to the progesterone releasing one. So the progesterone releasing contraception include Mirena, Kyleena, Skyla, among others. So these are more reliable because they are also progesterone releasing. So they release levonorgestrel, and the progesterone would give progesteronic protection, and the device itself, by sitting inside the uterus, will prevent pregnancy as well. So the side effects also related to the progesterone. So contraindications of inserting an intrauterine contraceptive device will include acute salpingo-phlebitis, purulent cervicitis, so basically infections. Adverse effects, the worst one that could happen is perforation of the uterus if it's done by untrained hands. This could also injure bowel, bladder, as well as migration and lost, where the device can be lost in the abdomen. You could also have lost strings, expulsion, where it accidentally comes out, pain and discomfort after insertion. Typically, this is self-limiting. Breakthrough bleeding, especially with patients that are using levonorgestrel releasing devices like the Mirena, Skyla, and Kyleena. Vaginal discharge, also self-limiting usually, and the risk of pregnancy, especially in the non-progesterone releasing intrauterine contraceptives. Follow-up of patients with intrauterine contraceptive device. Firstly, it will be You need to check the shape of the uterus before inserting the contraceptive device so that you curve along the curvature of the uterus, ensuring whether it's retroverted or anteroverted. Once it's placed, then immediate or soon after that, you need to confirm placement, making sure that it's sitting where it's supposed to be and it's not in the myometrium and there's no perforation, it's not in the abdominal cavity. Follow-up after 3 months should be done to ensure that it has not been expelled, and then you can do the checkups annually to do a scan, make sure that it's there. The patient can also be advised that she can regularly check for the presence of the strings, which are typically placed behind the cervix. And if the strings are lost, it's not really a big issue. All we need to do is confirm that the intrauterine contraceptive device is still within the uterine cavity and counsel the patient that she can continue using the device for as long as she requires. And when removal is then desired, this can be done using a hysteroscopy or with the older methods, the DNC or even the hook. The permanent methods, these include sterilization, mainly sterilization, including tubal ligation as well as vasectomy. I obviously don't have much to say about vasectomy. Tubal ligation, there's many types, but the common ones that we would use is the modified Parkland, should be having. So the modified Parkland is this one here where you ligate the one side of the tube and the distal side, and then you cut in the middle. The Pomeroy, this was the old method where they would just tie and leave it like that, but modified Pomeroy, then you tie the tubes, you take a loop, you tie the tubes, and then you cut on top. There's also has a bit of a failure rate because the two ends of the tubes are together, and sometimes you can get recanalization and joining of the tubes. The modified Parkland, it's quite a good one because the tubes are far apart and chances of them having spontaneous reanostomosis are very low. We can also do a salpingectomy where we remove the whole tube, and this also has added benefits. By removing the fimbria, we're actually reducing the chances of having epithelial ovarian cancer. We can also do this laparoscopically or open using the methods I've said, but the common one to use laparoscopically is a Filshie clip, where the tubes are clipped. Also, this needs to be done properly, making sure that the entire length and thickness of the tube is clipped and not just half of the tube. And the clip must be tightly played so that it doesn't slip out. So I'm nearing the end, and that's on the mark. So approaching a patient with who comes to you desiring birth control doesn't start and end with prescribing contraception. Patient doesn't come in and sit and say, "Doc, I need contraception. Please give me something," and then you prescribe COCs and then she goes. So it's a full consultation. So you need to take a detailed history, detailing all the complaints, the menstrual cycle, the last time she had a period. She might be coming to you and she's already pregnant, and the last period was 3 months ago and you missed it because of not taking a detailed history. You need to find out whether she has abnormal flow, dysmenorrhea, because this will also guide you as to which contraceptive method would be beneficial for her desire for contraception, but also for her gynecological issues that she also has. If the patient has had previous contraceptive use, it's also important to ask and see if she had adverse effects and what were the reasons behind his continuing. It's also an opportunity to see if she has had a recent pap smear, and if not, this can be offered to the patient. We also need to take a detailed medical history, including drug history as well as allergies. As mentioned, some of the contraceptions and some of the drugs, medical drugs given, might interfere with the active ingredients in the contraception. Surgical history, she might have had major surgery a few weeks ago and she would not qualify for certain contraception like combined oral contraceptives, as I've mentioned. Family history of cancer, as an example. Need to do a thorough examination, look at the general. I mean, this is basic things that we always do when we examine patients, but special emphasis, thyroid and breast. Make sure you check the blood pressure, the body mass index, special emphasis on that weight. Do a general exam. She might be having a mema, and because she's already has cardiovascular disease, and now that would contraindicate using certain contraceptive methods. Also need to examine the limbs. Maybe she's already presenting to you with DVT, and you give her combined oral contraceptives that will worsen her condition and increase her chances of morbidity and even mortality. So when prescribing contraception, we are guided by the WHO medical eligibility criteria classification categories. So these are 4 main categories. So category 1, the contraceptive method can be used in any circumstance. So this will be a contraceptive method that would not cause any adverse effect in any patient with any condition. So that will be classified as a class 1. A class 2 contraception, this is in cases where generally the advantages of using the contraception would outweigh the possible risks that you might have with using that particular contraception. Class 3, the risk of using the contraception outweigh the advantages of using it. So the final one, which is class 4, this is where the contraception is completely contraindicated and should not be used. So I saw that there's actually many apps, applications on the phone where you can, the particular one that I saw was a WHO contraceptive tool. So basically this is how the page looks like, and I'm not promoting them. I've got no relation with WHO at all, but I found it quite easy to use. So basically you just punch in the patient's age, any anticonvulsants that she's using, antibiotics, antiretrovirals, whether she's got any benign tumors. So all the information would be entered into that particular app. And once all the information is inputted, at the end, on the last page, it will give you possible contraceptives that can be used, as well as their eligibility criteria. So you can see in this instance, with the scenario that I inputted there, it said progesterone-only contraceptives would be a class 1. So that means there will be no issues. They can be used for this particular patient. Levonorgestrel releasing intrauterine contraceptive devices, also a class 1. Depo injection, Petogen, also class 1. And then where advantages outweigh the risks would be combined hormonal contraceptives and the copper IUCD, as well as the Mirena would be a class 3. So it's quite an easy tool to use, and it would guide you to see which contraceptives you should avoid for the particular patient that's sitting in front of you. So in conclusion, we need to optimize birth control counseling at every given opportunity, so every contact, and this should not really be just with consultations, but also with health education, antenatal classes, health visits, so all the contacts that we have with patients. Secondly, more importantly, we need to destigmatize birth control against all cultural and religious beliefs, and we must not use our own personal experiences to discourage patients from taking contraception. We need to promote the use of the long-term acting reversible contraceptives. Like I said, these are the most reliable ones, especially in younger patients where pregnancy might not be desired anytime soon. And we also need to increase access to emergency contraception. And that, ladies and gentlemen, it has become the end of my presentation. Thank you.
Awesome, awesome. Thank you so much, Depo. Sure. Yeah, it's a huge topic. I mean, it's a huge topic. I mean, if you were to pick emergency contraception, it's it's a whole presentation on its own if you choose the natural methods. And yeah, so I think you really summarized it quite nicely for us. And I'm glad you also showed or shared the app, the WHO tool that can help us decide which contraceptive to use. Thank you so much, Sep. I think that was, quite a mouthful and quite informative and quite practical as well. And I think for me, the take-home message is that when we counsel a patient for contraception, we don't say, Mama, which contraception do you want? She says the injection, and that is what she gets. Basically, to also, look at each patient and give them all the options and let them decide the one that they actually would like to go for. So thank you so much for that excellent talk. There's a few questions and comments. You're welcome to go through some of them, but I've sort of tried to group them together so that you don't have to go through each one of them in the Q&A. There may be one or two in the chat as well, but I think the Q&A ones are easier to address. There was just one question there by Pumlawe. He or she asks, how long would you resume your normal cycles after having used Depo Provera for 3 years? Any comments on that?
Yes. So regardless of how long she has used, a patient has used it, it typically takes about, for Depo Provera, it will take about 6 to 9 months to clear off the system. So it's quite long. And this would be important when counseling the patient, that if you are going to desire pregnancy within the next few months, maybe this will not be the option for you. So it typically takes about 6 to 9 months for Depo Provera to clear off. And for Nitrate, it will take about 4 to 6 months.
Okay. Awesome. Maybe before continuing, I saw there was a hand up. Maybe Alice, you could please assist. There was Dr. Randy Lamfel, a colleague who's at Pretoria, who had a hand up. I'm not sure if she, there we go. Thank you, Alice.
Good evening, everyone. Thanks, Dr. Abotata, for the wonderful talk.
Thank you. Thank you.
I just have a question. So I'm a registrar, right? So work in GOPD quite a lot and deal with a lot of patients who need contraception. And what I've noticed is that a lot of patients within the first month, when they come face to face with some of the side effects associated with the contraception, they usually want to quit. So patients with Implanon will want to take it out. Patients with Mirena will want to take the Mirena out. Patients on the pill will want to stop taking the pill. So I just want to know from you, how long is long enough to give a contraception a try and then to move on to the next contraception from there?
Thank you, Randy, for a wonderful question, and it's quite relevant. So I'm going to answer it in 2 ways. So firstly, I think we need to just overemphasize on our counseling when we consult with patients that need contraception, so that we can prepare them for the side effects. Some of the side effects, like amenorrhea, are side effects that patients can live with. But if it gets to a point where the patient starts having bothersome side effects that she is now no longer prepared to continue with the contraceptive pill, that will be the time to actually change. So it now depends on the contraceptive method that you're using. For some of the contraception, like the subdermal implants, it does take a bit of time for it to settle and for the body to get used to it. So I would say for the long-acting reversibles, would wait about 3 to 6 months. For the oral contraceptives, because the side effects are usually immediate and they might not improve, I would not continue with it for more than 3 months. I don't know what you think there, Billy.
Yeah, I think I agree, but I've actually learned that it's very difficult, to get the perfect contraception for a woman. I always tell them that, you might have to go through this journey where you actually try all of them until you find the one that's perfect for you. Of course, you guide her through that. So side effects have to be taken and assessed appropriately. So I think I fully agree. But when it comes to the counseling itself, the patient needs to be aware that it is not an honest pill or a method that doesn't have any side effects. They just need to be aware, and usually they can sort of, live with them and just get used to it. Until they find their perfect one, they just have to keep trying. So I fully agree that, thank you.
Absolutely, and I think that's the key. That's the key there. That because the side effects are not similar in patients, and you just need to try and see the one that would be more suitable for her, which might have not worked for her friend. So absolutely.
Awesome. There's quite a few questions that I think I really don't have to address, such as the availability of Mirena. We know it's available in South Africa, maybe not in the public sector, but some hospitals in the public sector do have. There's quite a few questions that have to do with drug interactions. I think you've shared the app, and maybe colleagues can actually use that so that they can get guidance whether or not you can use a certain type of antibiotic with a certain type of a contraceptive option. But there were some questions on the vaginal ring, how it should be inserted, the logistics around that, and how long can you keep it in, and the cost that is implicated should one choose that contraceptive option.
Yes, so it's quite flexible. So the patient inserts it herself. So it's more like, unfortunately, I was going to give an example and say it's more like inserting a pessary for a patient with prolapse. But it's so it's shaped like a donut. So you can actually compress it, and it will just slip through. You can use a bit of lubricant, KY jelly, and this is done self-administered by the patient, and it slips through into the vagina. It sits in the vagina for 21 days. So it is there to continue mimicking a menstrual cycle of a woman. So for 21 days, it will be left in place, and it will then be removed after 21 days. So from 22nd day onwards, then that's when the patient will experience withdrawal bleeding. Cost-wise, I think the last time I checked, they were selling for about roughly 400-500 rand. So it is quite costly, but it is available in the private sector. But like I said, because of the logistics of patient having to always check on the ring, she might go to the bathroom, and when she comes out, she thinks it's not there, and then the reliability will be lost.
Maybe let me chip in, Dr. Rabotata. There was a number of questions, but firstly, thank you very much for a great talk, quite comprehensive, a big topic, but I think you did justice to this talk. What I want to ask, actually, it's a number of questions around this postpartum or the use of contraceptives during breastfeeding. And most of the questions are asking, what are the implications of giving combined oral contraceptives during breastfeeding or during the first 6 weeks? So what is it that we are scared of? What are the issues there? Thanks.
Yeah. So combined oral contraceptives increase the risk of venous thromboembolism. So in a patient who's postpartum, we know that pregnancy and delivery has an increased risk on its own of thromboembolism, so DVT and PE. So when a patient that already has an increased risk, and the risk sort of reduces from the time she gives birth, every day the risk gets less and less as she moves further away from the time she delivers. So the main issue is with the DVT and thromboembolism. So when given in women that are breastfeeding and it's done, if it's done earlier, there is some amount of contraception that will be passed on through breast milk and will get to the baby as well. So the main issue though is with the increased risk of venous thromboembolism, and hence one of the contraindications as well is for patients that have had surgery. So if it's a patient that delivered, and maybe she delivered even by cesarean section, that will increase her risk of DVT even higher, and you'll be now adding on to her risk by giving her the combined oral contraceptive. So it's the estrogen part which actually plays a role in that, because it's thrombogenic.
Superb. We have Malerato. Malerato, you may unmute, and then we will ask, I think it's Dr. Molefi as well, to make a comment. Malerato, is that your hand? Is your hand up? Malerato? Okay, she disappeared. Okay, Dr. Molefi, you want to make some comments?
Yes, am I audible?
Yes, welcome.
Yes, you are.
Oh, thank you, Dr. Tata, for a good and well comprehensive presentation. I know we are all aware that there's a topic now that is happening in our country of teenage pregnancy, especially those teenagers that are between the ages of 10 and 14 years. So it's a serious problem in the country. So Dr. Tata, what's your take on that, and how would you advise parents in terms of contraception for those teenagers?
Thank you, Aaron, for that question. Yeah, it is, unfortunately, it's really a social question. The main issue is to collectively try and get society to understand that contraception is not as bad as it's been deemed for centuries. There's no long-term effects, because issues mainly with parents is that if you start a young girl on contraception, she would have sexual intercourse freely and willingly. The truth is that with or without contraception, they are having intercourse. So this is more of a protection. But on the other hand, there's also fear that long-term usage of contraception reduces fertility and might result in a failure to conceive when the time is right. So we just need to demystify those myths, and collectively, like I said, it's a social issue. It then requires politicians, requires leaders, religious leaders, and leaders in communities as well, to ensure that proper information is disseminated, and also to give more information, and also the power to the young girls as well. And I think maybe, the young girls should be given an opportunity to present themselves, to come and say, I would like to start contraception, without even having fear that the sister at the clinic will turn her back.
Yeah, Dr. Magagula, would you like to add your comments on this question and maybe talk to how the availability of the different modalities in the public health system, and what we can do to increase access in that space? Doc?
Yeah, I think I agree with Depo. It's really a multi-faceted challenge, the issue of teenagers and pregnancy. Yeah, it's really bad, and unfortunately, this is the reality for many of us who are also in the public sector. The availability of long-acting reversible contraceptive methods, it's really a challenge. I actually saw one question which I thought would be a very classical Mawela question towards the end. How do we improve the uptake in the public sector? So yeah, I think Depo just dodged the bullet there. But nonetheless, I think our public health system needs to make these contraceptive methods available. I mean, to start with, we know the Depo or the nest rate is quite fashionable, the whole of Africa, not just South Africa. But if you were to look, the availability of it, it's very limited. And then you come to the intrauterine contraceptive devices. They are not that expensive. I mean, the Nova T380, it's less than 1,000 Rand, and I mean, it stays there for about 5 years. But again, it's not routinely available. I mean, if you talk about Mpumalanga, and a patient opts for the best, which is your subdermal implant or the Implanon, people have stopped putting them in because there was a whole issue about the use of Implanon and HIV, and the device being lost, and just the whole way that the program was actually put in or started was just really chaotic. And now, I mean, at the hospital where I am, there's no Implanons in the whole hospital, which is supposed to be a tertiary institution. Of course, I won't mention where I work. So you can imagine, and how many teenagers do we see who need long-acting reversible contraception, either after a miscarriage or they've just had a delivery, and you really want to give them the best, and it's not available. So it's the unfortunate sad reality. But I mean, of course, those that can afford, they go to private healthcare workers and they're able to buy these contraceptive methods privately. But yeah, it's really sad. And I think, engaging the public, educating the mothers, educating these young ones, even at the school level, so they get the HPV vaccine, and you tell them about contraception. because already they are engaging anyway. So yeah.
Okay, let's hear from Dr. Tulani Khoza.
Good evening. There's a habit of injecting young girls immediately post-delivery in the public sector. I find it sometimes disturbing when they come with DUB. How do you feel about that? I thought one would wait until they regain their menstruation period. Can you hear me?
Yes, just
Hello?
wait. Dr. Ramthatha,
Yes, no, I think I got the question.
Okay, thanks.
Yeah, so yeah, firstly, the issue of injecting everyone, I've worked in government as well. I mean, I've seen it where post-delivery, everyone is injected, and sometimes without consent or even thorough counseling and giving the patient option to choose. So I think that in its own is wrong. But if a patient is post-delivery and the counseling for contraception for a patient that's post-delivery should have actually begun during the antenatal period, and it should be documented in the maternity case record. So by the time the patient comes in, we'll already know that she has opted for Depo Provera injection, and this is what she will get, or she has opted for oral contraceptives, and she cannot be given during this period of time. So the counseling should start then. No one should actually be forced to use contraception. We just need to make sure that they get appropriate information, and if the information is good enough, most of them will opt in. But if a patient has opted for injection immediately post-delivery, absolutely, it can be done. There's no contraindication. Immediately post-delivery with no risks, among others, as well as including the intrauterine contraceptive devices. There was actually a study done by one of our colleagues, Sanele, that showed that the uptake of intrauterine contraceptive device, mainly the copper T post-delivery, was quite low. And I think it probably has to do with just the lack of information, and that is our part where we need to educate more and more patients on the availability of these contraception. But definitely the practice of doing it without the will of the patient is wrong, but it can be done safely. Postpartum patient can get, where I trained, we used to have a phrase where we say, is the implant on in, while the patient is even in labor. She has not delivered and she's in labor, and the consultant will come and say, is the implant on in already? So that just shows that we can, most of these, it's actually the combined oral contraceptives that have a bit of a challenge, but with most of them, they can be used immediately postpartum. Thank you.
Yeah. Dr. Magagula, I'd like to take more hands. Do you have any questions you want to deal with from the Q&A box?
I think I'll just group the ones that were talking about age, whether or not we should be using, or opinions around the use of combined oral contraceptives after the age of 40. There's one by Dr. Masego Ngamsile. There's another one by another colleague who's asking after the age of 35, why can we not use? I thought it was a relative contraindication, but perhaps maybe clarity, a little bit of some words from Tsepo regarding the use of contraceptive after 35.
No, absolutely. It's definitely relative. It has to do with the fact that the older the patient, the higher chance of having metabolic syndrome, diabetes, and hypertension. And that's why I said it is quite relative. So it shouldn't be an umbrella approach to say that the patient is older than 35, you can't give a combined oral contraceptive. So it's quite relative. And I think even where I got the data from, it's probably one of those, those answers that you would give to say poor socioeconomic status, or so it's a no-brainer. Definitely a relative risk. And like I said, we've done it before many times. I continue to do it now. We still do it even for patients that are even close to menopause or in the perimenopausal phase who are a bit younger, and we don't want to start them on hormone replacement. We just put them on combined oral contraceptives and they get the benefits of hormone replacement. Thank you, Nami, for the question.
Yeah, let's take ahead, colleagues, 5 more minutes and then we will be summing up. So we'll take 2 hands and then 1 question from the chat, and hopefully we start to do closing remarks. Geraldine Benera, are you able to unmute?
Yes, can you hear me?
Yes, loud and clear.
Oh, okay, thank you. Well, maybe I might have missed it, but we have seen quite a several number of patients. Maybe they smoke like 10 or 15 cigarettes, or the one who comes with, they've been having malignant hypertension, and they were trying to keep it in control, but still it's too high. So now this client comes and walks in and they want family planning, the pill. Are we to turn them away to say your condition doesn't allow you to have COC, or what is the alternative? What is the safest for someone who smokes, or that malignant hypertension, or that BMI which is very high? What is the best for them, if I may ask?
Thank you for that, Dr. Rabotata. As you respond to this question, maybe also outline, there was a question around how do you choose? Maybe these are linked, because I think there's a number of options. Yeah, take us through, Doc. Thanks.
Yeah, okay, I'll start it in opposite. The choice depends on what you want to achieve, also depends on the patient sitting in front of you, depending on comorbidities as well as undesired effects. So that is how you would choose. And remember, the patient, like Billy said, the patient would walk in and say, I want oral contraceptives. So your duty is not, you're not a pharmacist, your duty is not to give the patient combined oral contraceptives as required. So your duty will be thoroughly take your history, examine the patient, and then advise the patient on options that are available for her. And so in a patient like that who's smoking, high BMI, metabolic syndrome, you want to completely try to stay away from hormonal contraceptives, especially the combined oral contraceptives. You can look at things like intrauterine contraceptive device, the copper T, because that is non-hormonal, doesn't release any hormones, unless if there's certain contraindications to it in that particular patient. But the main issue here is that if a patient comes in and says, doctor, my friend is on Yasmin, her skin is glowing, and I would like to also have skin like her, please prescribe Yasmin for her. It shouldn't be like this. So it should always be individualized as per patient sitting in front of you. And we actually learned that with practice, because there is no umbrella approach in medicine. I don't know if I've answered the other question as well, Billy. You happy with that?
Yes. Yeah, no, you've covered it. Thank you.
Yes.
Ellis, do you have any more, or should I maybe add 1 or 2?
No, Ed, then I'll take 1 more voice, which is the last voice we will take. Thanks.
Okay. I think the one has to do with basically informed consent, where the participant is asking with regards to long-acting reversible contraceptives, such as your Implanon or your subdermal implant. I suppose one could actually add the IUCD. Does one, if it's a teenager or a child, do they require any input from the parents? And then the other thing, I think you've already answered, the use of the safety of Depo or steroid post-delivery for these young ones, that absolutely it can be used. Yeah, but I think just to address the issue of consent and the involvement of the parents.
Yeah, the consent with regards to contraception is actually more of implied consent. And with the landscape of things going forward, I think that will most likely change, just like many other things that are going to change. You are going to have a situation where you need to take consent to examine a patient, especially if you're a male doctor and you're examining a female doctor. So what is currently available, and I think you can also attest to this from the work you do in the public sector, it's mostly implied consent, and with discussion and documentation in the notes that patient has been counseled and has agreed for a particular contraception. With the invasive ones, I think it would be more beneficial to get some form of written consent, especially especially the intrauterine contraceptive devices, because now the risk of complications, especially in the wrong hands, the risk is slightly higher, and you don't want to put in an IUCD in a patient that you thought it would be easy, and the next thing she comes with a perforation, and she says, "But doctor, I never gave you permission. You never informed me about the possibility of bowel injury or perforation of the uterus. I would have not taken that particular option had I known." So it's really moving in that direction. The issue of parents and contraception, whether contraception, I mean, parents are required when children are coming in for contraception. There, I'll be lying. I don't know, Billy, if you've got any information. And actually, I think it's quite something that is important. The access to contraception should be free for all. I'm not sure what the legislature actually does say there, because that would be something that should be written down on legislature. Lesel would most likely have a response and definitely be there.
Yeah, today I'm an obstetrician, Dr. Ravutata. But colleagues, we had a very important session on informed consent.
Again.
Just wait a bit. Okay. Sorry
I
about
think
that.
Dr. is on the
Colleagues,
phone
I was
then.
just saying that on the clinical library, there is a micro lesson on informed consent, and it covers the rights of women to access sexual and reproductive health services. And the law currently allows women 12 years and above to consent for sexual and reproductive health services without parental consent. Obviously, this is not written consent; it is implied. But try to write, your notes in your records carefully, and let's get it right. So I think that is the context. Yeah.
Thank you, Lesego.
Yeah. Let's get Socrates. Socrates, you may unmute. Colleagues, we will close down in the next 5 minutes. Socrates. Socrates.
Hello, thank you very much, Dr. Magagula and Dr. Rabutata, for the excellent comprehensive presentation. Yes, on the morning after pill, you mentioned that you give it in a contraceptive in 2 divided doses, but I've noted in the crisis center, they give 1 tablet, Espel or something like that. What is the difference? Sorry.
I'm not sure what drug is that. I don't know if you know about it, Billy.
Yep. Remember, if you use oral combined contraceptives, where you were giving examples of orals and so on, but your next slide spoke to the once-off doses.
Yes.
The 2 doses. Why sometimes we are using BDs or once-off. So there's a newer, better ones.
Yes. Yeah. No, I got the question. There's most likely the one that he's mentioning. I'm not familiar with, so I couldn't get the name clearly. But even the slide that I had would most likely be a little bit vague. You can actually use the 2 levonorgestrel tablets same time as a state dose, which will be a dose of 1.5 milligrams. So chances are it might be a new generic that is a combined dose. Yeah. So you can either use the 1 pill and repeat after 12 hours, or the 2 pills at the same time. The one that Doc is talking about might actually be a generic that is combine the 2 tablets just to make it easier for administration.
Yes, Alida, do you still want to make a comment or a question?
Yes, Doc. I just want to, in my hospital where I worked, when they want to put in the subdermal implant on HIV positive women, they do say the period of time that the implant must be inserted will be 2 years and not 3 years. So has it changed to 3 years for women who's HIV positive when they want to put it in? The time period is 2 years.
Yes. I've actually also heard about this happening, and I think the concern was more that patients on certain antiretrovirals due to drug interaction might have increased uptake of the drug, but I'm not sure if this was substantiated by any form of trial or study to look at it, and maybe colleagues can help if there is anything that was done to actually prove. But I've heard that there are areas that would only put in the subdermal implants for 2 years in HIV positive patients that are on antiretrovirals, mitigating that if there's drug interaction and increased uptake of the progesterone in the rod, then the patient might have a whole year of no coverage. But I don't think I haven't come across any substantial evidence to show that that is indeed the case. I'm not sure if you've seen anything, Billy.
Yeah, no, fortunately, we've got the HIV specialist, Mawela, so he's going to assist. But I think that was really true when you think about nevirapine-based regimens, perhaps to a limited extent, efavirenz. But with the new regimen, dolutegravir, and I don't think that is really the case. But nonetheless, let's always remember that we always advocate for dual contraception. So the implant always goes with the condom, the pill always goes with the condom, and this is just to make sure that we have better efficacy. But Dr. Mawela, please, your input on this one.
Yeah, no, thanks, Dr. Magagula and Rabotat. So I think these are drug-drug interactions. There are drugs that are known to be liver enzyme inducers, and therefore, if taken together with your hormonal contraceptives, they would then increase the metabolism and therefore reduce the durability or effectiveness of these contraceptives. We prefer dolutegravir in this instance because there is no significant drug-drug interactions. But you might find patients on efavirenz, nevirapine, lopinavir, ritonavir, where the effectiveness of your contraceptives would be reduced. I want to give a quick, when we started with the pharmacovigilance program in the country, there was a case of a young woman who had an implanon, who presented with an ectopic pregnancy. And obstetrically, that was dealt with, but no one asked, why would you have a young woman presenting with an ectopic pregnancy when they have an implanon, 6 months down the line, she came back with a second ectopic pregnancy. That is when she was reported through the pharmacovigilance program for the HIV/AIDS program nationally. And the key thing is that as soon as women start spotting when they are on these long-acting family planning options, you have to be very, very concerned. And that's why the issue of dual contraception with condoms is so important. Remember, TB treatment, rifampicin, is actually a huge liver enzyme inducer. And if any woman is taking hormonal contraceptives with TB treatment, you would expect a similar issue to appear. So these are, we can never know all drug-drug interactions from our heads. And I think the app that Dr. Rabotata shared, it's quite important that as you initiate any treatment, you always check potential drug-drug interactions and make sure that you can counter the effect. So quite important in that instance. All right. Dr. Rabotata, Dr. Magagula, can we start summing up? I think Dr. Rabotata would need to come back and focus on a specific family planning option and really give us more. But I would like Dr. Mvula, our colleague from Namibia. Dr. Mvula, I hope today your audio is working. Just to give your commentary and appreciate today's talk from Dr. Rabotata.
Good evening, colleagues. Can you hear me today?
Yes, better.
Very well. No, thank you very much, Depo. I think I commented in the chat box that it was a very comprehensive talk as always. Thank you very much. And I think nothing much to add except that I think everything was discussed. except that I think we must just do our best to raise awareness. I still believe that there's still lack of awareness. And I think we perhaps need to do more, especially regarding the myths around the contraceptive use, especially among the teenagers, and who we should be targeting so that we know the dangers and the complications of teenage pregnancy in terms of not only pregnancy, but also long term with regards to the issues surrounding socioeconomic and poverty. So I think we just need to raise awareness and really promote the long-acting reversible contraceptives among our youth. Thank you very much, colleagues.
Thank you.
Thank you, David.
Dr. Magagula, let me hand over to you, and then Dr. Rabutata to also do his closing remarks. Thanks.
Thank you so much, colleagues. Unfortunately, we couldn't answer all the questions in the Q&A, and I'm aware that Alan has asked whether or not we use ulipristal acetate for emergency contraception. I think absolutely it's one of those big four that we can use. But I think generally the talk was really comprehensive, guys. You can hear from the interactions and the discussion on all the Q&A and the chat, and the hands. So it really stimulated our thinking cells. So thank you so much, Depo, for that. And your opening slide and your last slide where you are showing us the VAL, I really wish I had taken a post in the VAL right now. So thank you so much for that. We really appreciate it. And I think we'll be talking about the flip side to preventing pregnancy pretty soon. Looking forward to that. Otherwise, a good evening to all the colleagues, and thank you so much for attending.
Thank you. Dr. Rabutata, closing remarks. Are you happy?
Thank you. Yeah, the question that Alan had on ulipristal, I'd actually taken it out based on this not so long recent evidence that started showing that there's quite a risk of increased hepatocellular carcinoma. And I think they're looking into it. And the last time I checked, it was pulled off the shelf, and I think that's when it was just entering the country. I'm not sure what is the status on it, if you know if anything has changed, Billy. But I think it was pulled off the plug, and they are still looking into it. But it might be back. I mean, Alan graduated recently, so he might be having a more accurate recent information. But I'd like to once again thank you, Lesego and Billy, for really inviting me. It's been a great honor and pleasure. Although, yeah, the day was a bit upside down with deliveries everywhere, literally, including the streets and by the traffic light. But the talk I really enjoyed the interaction. I think one thing that we need to always remember is that we are here to serve a purpose, and the purpose we have is always bigger than us. Contraceptive use can save a woman's life. There are young girls that are going around who fall pregnant, and they try to have unsafe termination of pregnancies, and some of them end up losing their lives. So it is definitely not a topic to be taken light. And you should actually see how we talk about contraception with patients, especially in private practice, because there's always free will. But it's something that should not only be done in private practice, should be done everywhere across, especially in the most important areas. And these are the smaller clinics that are in the communities where the people are. And these areas should be more accessible, and patients should be free. Young girls should be free and come and say, sister, I need contraception. I've started, I'm 15 and I'm sexually active. I don't want that pregnancy. And we should do this without any judgment. But usually when I talk, I don't stop. Thank you once again.